All right, welcome to our Q&A session, our weekly. Simon, you got the Q&A. There's some questions already submitted. Oh, you're frozen. Sorry. Can you hear us okay? If it's just me. If you're okay, good. This is sharing screen. Okay, terrific. And if you have other questions for those who've just joined us, welcome to our Q&A session weekly. Just type in your questions and we'll try to get everything answered. If not, we'll carry over next week.
Okay, so first question, when should the 6-year-old molars ideally be in class 1 occlusion, given that both upper and lower sixes should be moving forward into leeway space after the 4s and 5s are up? Is it normal for them to initially erupt in class 2 and then shift into class 1? So we have very specific primary dentition classifications that we follow, just like we have permanent molar classification that we follow in the permanent dentition. So in permanent dentition, class 1 molar relationship has the mesial cusp of the lower sixes ahead of the mesial cusp of the upper sixes. In the primary dentition, we classify the second primary molars, the E's, and we classify them either as a distal step, flush terminal plane, or a mesial step. In a distal step, we always end up as a class 2. In a mesial step, we end up in either a class 1 or a class 3, and flush terminal plane, we end up in a class 1 relationship more often, sometimes class 2 relationship. We also have an understanding that the sixes are held distal to those E's in the same relationship. We know leeway space is about 2.5 mils on the lower and 1.5 mils on the upper. So there's more mesial drift in the lower arch than the upper, which is why a flush terminal plane will be quite normal to precede a class 1 relationship when we have our teenage or permanent dentition. More importantly, you can also assess the primary canine relationship because that tends to be representative of the long-term relationship. So when should the 6-year-old molars be in class 1? Very often they're always in class 1. In class 1 growth, with possibly being 2 mils and 1 mil of leeway space closure in the lower and upper arch, then you've got a little bit closer to end-on type relationships being still possible. But if the canines are in full pass 2 or full pass 3 in the primary dentition, then don't expect the sixes to lock into the class 1 no matter what the leeway space is. So we want the sixes always to be either flush terminal plane or a slight mesial step at the eruption of the 6-year-old molar timeline. And from then onwards, it will, at the closure of leeway space around 12, 13, when the 7s erupt, it will move from either class 1 to class 1 or flush terminal plane to class 1. Second question, can you explain how you use the Wits analysis to determine a class 3? So Wits is taken off the occlusal plane and the deepest curvature of the alveolar bone at the basal dental alveolar junction. So A point is dropped perpendicular to the occlusal plane, and B point is raised perpendicular to the occlusal plane. And if B point is ahead of A point on that occlusal plane, then you've got a class 3, because A point should be very slightly in front of B point for a normal class 1. So we're using occlusal plane and we're judging A point and B point relative to that occlusal plane. With class 1 having A point ever so slightly ahead of B point, and class 3, B point is usually ahead of A point. Combine that with your SNA and SNB, and usually you can verify along with your dental relationship that you have assessed in your angles classification. Excuse me. When do you straighten out the cat wire loops? What are you looking for? So in expansion, we can often get a lot of transverse dimension change. The screws allow somewhere between 4 to 10 mils of expansion, depending on whether you're looking at a lower arch or an upper arch. That widening is a degree of expansion that will create a shortening, relatively speaking, of the ends of the cat wire loops. As the two halves separate, you have less contact of the wires with the incisal teeth. I created a bank of extra wire on the end of the loop, which can be unraveled to get more cat wire loop ends. The control that we have of the incisors is better at the ends of the loop compared to the starts of the loop where they're near the acrylic. So if I want some form of control of the laterals, for example, I would prefer to have that controlling wire be the free end of the cat wire. As we expand, that free end draws more towards the midline and moves away from the laterals. If I have extra wire in the form of a loop back, then when the free end of that cat wire steps away from the other side's lateral, then I can unravel the loop and put the cat wire end back into contact with the lateral. So what am I looking for is when the end of the cat wire is moved too far away from the opposite lateral, then we unravel that loop to recontact the end of the wire with the lateral. So certainly after you expanded 3-4 mils, that will start to become obvious. And certainly by, say, 5 mils of expansion, you'll need to start unraveling that wire if you want it to contact. It's predominantly for upper arches when you have an ectopic lateral that's erupting palatally. All right, next question is regarding the chewing exercises. If we are worried about them breaking the class eating with the appliances, can we have them use the chewies at the dinner table with the appliance in place prior to eating, then take out the appliances to eat and immediately put them back in? My protocol is for the appliances to be worn in function, so I don't have them take out their appliances when they eat. When you allow a child to take their plate out when they eat, they will lose their plate. Their plate will end up in a dumpster. Parents will do dumpster diving in the back of the restaurant, and it's all very unhappy. In addition, when we have the plates out, when we eat, more often than not, even if we don't lose it, it ends up in the pocket and stays there until the next meal. Before you know it, a whole day has passed, you haven't worn it. In addition, it creates issues with the plates not fitting properly as they're going in and out and in and out, in and out. As how often do kids just have main meals? No, they have a morning snack, and they have an afternoon snack, and then they have a before dinner snack, and then just have a little snack just before they go to bed, and before you know it, it spends 6 hours a day in the mouth as opposed to 23.5 hours a day. Breakages of the class are rarely to do with eating. It is always to do with the kids flicking the plates in and out of their mouths, playing with them. So it's very rare that you'll get a functional breakage. Almost all breakages are related to non-functional bad habit breakages. Taking the plate out by flicking it, punching it home with their teeth instead of their fingers and thumbs, taking it out multiple times because they're flicking it and playing with it versus taking it out twice a day. So it is not very common to have wire breakages in function. It is almost always related to adverse habits of them playing with the plate and not following the protocols. In deep bite situations, why not build the bite ramps up a little higher to protect the clasp from the wires and then adjust them down a bit later? So occasionally when you have an extreme deep bite, then yes, you can raise the bite with acrylic. And yes, you can remove that acrylic a bit later on, but it's not common for young children to have 100% deep bites. So it's not something that needs to be done on a routine basis. Certainly on a case-by-case basis, we can certainly do that. Removing acrylic and not damaging the wires underneath takes significant skill and very few novice clinicians can do it without basically wrecking the implants. So that's something also to consider. Next question, where exactly should half-inch crossbite flange be positioned? Close to the 6 or the E or right in between? So I usually put it in between. If it's primary dentition, then around the E. If it's mixed dentition, between the 6 and the E. And it's always very slightly directed towards the midline, so as to conform to the expansion of dental alveolar ridge on the palatal, on the lingual side of those mandibular molars. If traditional ortho only expands the upper arch with a fixed palatal expander, how do they typically manage the scissors bite if not bracketing at the same time? So generally, if the expanders in phase on ortho are used, they're either done with a bite opening bite ramp that covers the molars, or they're done without acrylic componentry. So they're either band cemented or the acrylic covers and envelopes and is cemented on to all the molars in bite opening cases. So that's generally how they manage it. It'll either, if there's no concern with interferences in the crossbite, then they'll just cement like a Hyrax on the molars themselves with no bite opening, or if there is a concern that they'll have trouble managing the functional shifting, then they'll usually have acrylic coverage on the molars and the bite will be open. So that's usually how it's managed, but in asymmetric maxillars, they run, irrespective of the technique they use, into the problem of upper excessive expansion on the broad side with no real change on the narrow side, exacerbating the malocclusion with the crossbite being broader on the good side. Sorry, the bite, that's the good side shifting into scissors bite, whereas the crossbite side remains the same. So in those circumstances, they tend to use the bite opening, raised blocks to cover the molars, and if they run into issues, then they will bracket or band up the lower arch with like a lower lingual retainer, and then they'll put brackets or bands on the 6s, and they'll use elastics, cross arch elastics. So yeah, as long as you know what your issue is, you can come up with a means of managing it with the equipment that you have. Next question is, what type of bird beak pliers do you use? So there's two basic bird beak pliers. There's the short, stubby ones and the long, fine nose ones. I use both. I prefer the shorter ones, but the fine ones I can open the cat wire loops with, but you need something that is of reasonable quality if you're using a fine bird beak, because they need to be very rigid or they flex. But yes, traditionally there are short and long, and you can use either, you can use both. The easiest thing is just to get a few, get a short one, get a long one, and then you'll be able to figure out what your preference is for the design. Some have the short ones tend to have broader, the finer ones, the longer ones tend to be skinnier. So some manufacturers have a kind of middle ground too, so you might find that works for you. I have experimented with different shapes and sizes over the years, so I've got far more pliers than I need, and that allows me the luxury of picking the right size and shape for each circumstance and situation, which is probably how most people end up. You know, you buy some of the short, you buy some of the long, and you like this brand, you get a special on that brand, you buy some of this. It turns out to be a different size, and then all of a sudden you've got like 20,000 of them floating around, and they're all different sizes and shapes. Fortunately, that gives you the option of, you pull one out, it doesn't quite fit the wire that you want, so you have a look at a different size in your rack and you pull out the other one. So, unfortunately, it will vary, but there's two generic sizes. During expansion, is it necessary to trim fit surface appliance due to changes of the palette? You know, when I first started, I would, if there was like really high palettes and weird shapes, I would smooth things off. But over the last 10 years, I've stopped doing that, and it doesn't seem to make any difference from my perspective. I just expand, and when the shape evolves through the expansion and it's time to make a new one, it you know, various reasons has flattened out on its own. I can't remember the last time I trimmed the fit surface of a maxillary expansion appliance. I used to do it all the time when I first started, but can't remember where I stopped, but it doesn't seem to make any difference in my hands. Next question. You mentioned that once the sixes are up, boys intermolar width will naturally grow another 2.5, and girls a mil less. What's the time frame for this growth? Yeah, it's about 7 years of age until about 12 years of age. The 6-year-old molars will naturally expand somewhere between 1 to 2.5 mils. So we would expect a 7-year-old intermolar width to be around 36, 37 mils if it is going to reach the required 37, 38 mils in natural growth by the time their sevens are up. Can you explain what you're looking at before equilibrating a primary tooth during your expansion phase. I'm never sure when to equilibrate and where. Just interferences to maximum intercrustation at the time and trim it. So I don't do any equilibration until I finish my expansion and leveled out the permanent molars with the rest wires. Then when I feel like I'm done with the development of the upper and the lower widths, and I flattened out the curve of Wilson and Spade, at that point, we are trying to get as much contact in occlusion as possible. And that's when I take out the articulation paper and check. And, pretend you're doing a full mouth rehab. You want, fairly even contacts. It doesn't have to be perfect intercuspation. We just want, every tooth in the primary dentition in some form of contact with its opposing teeth, and you'll get a sense if there are certain teeth that are in premature contact, and particularly unworn cusps that are present in the primary dentition are the culprits that usually hold the bite up. And you just take your burr to those unworn cusps and just flatten it out. And usually that will give us a reasonable level of equal contacts. And that's all you need. It doesn't have to be a perfect rehab. It just needs, most teeth touching in the bite. We also want to assess if we're a class 2 or class 3 relationship. If we're riding primary canine ramps in closing that lock us into class 2 or class 3 relationship. And in those cases, we will equilibrate those side mesial or distal guiding walls of the margins to the cusp tips. And if it's locking us into a class 3 or locking us into a class 2, then I will reduce that tooth surface so that the jaw can slide a little bit further forward in a class 2 or a little bit further back in a class 3. And again, at the end of the arch development phase. Next question. What is your opinion regarding patients, teenagers, adults who have extremely tight buccinator muscles? We have several patients like this who we as dentists struggle to do an exam. Fighting with the cheek and tongue, I have a teenage patient currently in braces with local orthodontics, can't seem to even brush his own teeth properly due to the tightness of the muscles. Myofunctional therapy. Postural exercises to get the tongue up to expect antagonistic muscle relaxation of the buccinator muscles. So usually very tight orbicularis oris muscles and buccinator muscles are due to hyperactivity of the facial muscles. So this might be a natural tendency, or it could be you've had a lot of myofunctional therapy to tighten those muscles, but usually through kind of natural progress, they're more often than not the deep bite class 2, division 2 patients. So you have to find a way of deprogramming those muscles. Certainly reducing the freeway space is very important. Helping them to learn to swallow with their teeth together is very important. More often than not, the braces themselves will act to dissuade them to squeeze their lips back because it's uncomfortable for them to do so. And in some cases, the orthodontist will put in a lip bumper to guard against the lips coming back in. But yes, myofunctional therapy would be important to teach them to relax their lips. But generally, the GoPex and the GoFX exercise program that I've created will help to increase the internal elevator muscle tone and decrease the external facial muscle tone. So do you ever use combination of appliances like expanders for a few hours in a day, followed by myofunctional exercises for a few hours? Combination of expander and oral screen together. So in my practice, no, I just use the appliances full time and the exercises for those 15-20 minutes a day with the appliances in place. Other than when we are wrapping things up, we are doing our exercises with the appliances out of the mouth. Lately, I've been experimenting with froggy mouth, which is an appliance that enforces a lip relaxation with a closing down of freeway space and habitual reflex retraining of the swallow, teeth together with no lip involvement. So that might be useful for the high facial tone patient as well. It's a simple device that can be used when the bite relationship has reached a reasonable level with reasonable arch form and occlusion and space for the tongue. So that's a finishing appliance that we use in conjunction with GoFX, good oral finishing exercises. So that might answer both 12 and 13 in the Q&A section for today. So froggy mouth is an appliance, a myofunctional appliance designed by a French orthodontist. It is held between the lips. It keeps the lips from contacting each other and is managed by maintaining a zero freeway space rest posture, and it forces a tongue to palate swallow with no lip and mentalis involvement. There's a little bit of research to validate its use. So something that I've been playing around with, but haven't decided if it's something that I'm going to incorporate my teaching as yet. All right, we've got a few minutes left. Anyone who has any other questions?
Yeah, any questions from anyone? We've already answered everything that's been submitted. While we're waiting for any last questions coming in, for those of you who are guests, if you have questions, if no other current students have any questions, we can open up to guests. And also, we just had our 2-day intro program over the weekend, and recordings. We have a pre-sale. They're not quite ready yet, but next week sometime they should be finished editing. But if you want to get our pre-sale special for the recordings, it's just 147. Send us an email, and we'll put you on the pre-sale. There you go. That's an email here. There's a few guests on, and if you want to join, watch the recordings of our 2-day event. That's something that we do normally once a year, but we had an extra event this year and last weekend. So, so I thought I'd quickly mention it for those who are guests tonight. If there are no other questions, we can let Simon have a bit more of a lunch break, I guess. Simon, anything you want to add?
No, it sounds good. All right. Thanks
All right.
everyone
So
for
we'll see everyone
listening.
same time, same place. Oh, actually, there'll be a different Zoom link. So just to clarify, Simon will be on, 3 out of the 4 weeks. Sometimes his lunch break is cut short due to emergencies or work. So we'll notify everyone if there's anything on the following week. We'll email everyone. And there is a link that we asked Dr. Wong. I'll send everyone the link again, where you can check in to see if there's a session on the coming Wednesday. Actually, it's someone. That's about it. All right, guys. Thanks so much. Have a good one.
Thank you.